Good afternoon. Thank you, Dr. Abdullah, for the invitation. It's a pleasure to be with you. It's indeed, obesity, I think, it's been there for a long time, but I think now we have the tools. That's why it's really becoming a major topic. So this is the American Heart Association report last year about the trend of global cardiovascular mortality. And if you see, I think we have a pointer. Do you have a pointer? No. So you can see that in the early 80s, yeah, thank you. This is when the statins started actually, mid-80s, significant reduction in cardiovascular mortality. Similarly for men and women actually, and I think much more advances in technology, medication. Something happened 2010. There's a significant increase in cardiovascular mortality. Literally we're back to where we started. So the report is about 30 pages. There's lots of theories. I came across this paper published in Nature Cardiovascular Research 2 months ago, which is fascinating. They're looking at over 25 years of changing cardiovascular phenotypes. And it's striking. Look at the orange bar. This is severe obesity over the last 25 years. We're talking about BMI of more than 40. Increased severe hyperglycemia and eGFR. I think that was really a very important concept, that when we're practicing cardiology 20, 30 years ago, I remember this is the patient that we used to deal with. The lean, stressed, chain smoker CEO. Now this is what we deal with now. The sedentary, overweight laborer with the metabolic syndrome. So yet the cardiovascular mortality increase for different phenotypes. And I think this is an interesting aspect for us. So there's not only one aspect in reducing cardiovascular risk. It's about cholesterol, inflammation, thrombosis, triglycerides, diabetes, hypertension, and we need to add obesity. I think this is something that adds to the global look at cardiovascular outcome. So obesity is a serious chronic disease. It's a global problem, and there's a direct correlation between BMI and life expectancy. As the BMI increases, life expectancy decreases. The consensus statement for obesity from 4 societies, it's a highly prevalent chronic disease, which is important. Fat accumulation requires lifelong care, and of course associated with diabetes, heart disease, and cancer. There are multiple factors for obesity. As you can see, genetics, behavioral, immune, medical, and so on. And we look at obesity in the context of assessing BMI, which really works for us. But I think ethnic differences are important, European versus Asian, body weight and what have you. And also we need to add waist circumference. I think that adds to the accuracy of assessing obesity. And we start doing this. I think in our clinic now for the first time, we measure BMI, we measure muscle mass, because we are using the anti-obesity medication now. It's a cardiovascular medication. And most importantly, when you assess the waist, you're looking at the adiposity, the intra-abdominal, which is the culprit for most of the problems with obesity. And actually, waist circumference and waist-hip ratio are much accurate measures than just looking at BMI. This is looked here in this study of 8,000 patients, and as you can see that the p-value is much better for the other 2 parameters. And of course, we know all that the obesity is associated with multiple comorbidities, huge impact on cardiovascular disease, and particularly recently linking HFpEF to obesity. And I think some of these medication work on this regard. How do we approach treatment? I think we talk about lifestyle changes. It works. You need to combine diet with physical activity, and it's a behavioral issue. It's a huge disease. I think it's not hypertension, you give medication. Patient have to be, you need to talk to your patient about the way to approach it, the failures. And if that doesn't work, then we have pharmacological therapy and bariatric surgery. So lifestyle, there are many wrong issues here. The remote control, the Coke, the treadmill is for the dog. So physical activity works, but very much limited. You may get 1 to 2 kilos with very persistent physical activity. You have to combine it with caloric deficit, and I think it works. Now, diet is the issue, and there are multiple dietary programs. They are very good if you persist on it. And as you can see here, there's a huge percentage of dropouts. I think intermittent fasting and, so it's a huge, now we're getting involved in this because the medication that treats obesity is something that we use. So therefore, I am one person that use a lot of anti-obesity therapy. Lifestyle intervention does impact cardiovascular mortality and morbidity. And bariatric surgery does work. There's criteria for this. You have to have a certain BMI. Now there's banding, there's balloons, but I think the most common one is gastrectomy. This is the most operation that's been used, and it yields the best weight reduction. And of course, this is nearly 200,000 patients followed up and showed it does impact heart failure, stroke, MI, and mortality. Medication. I think medication for weight loss has been around for a long time. The appetite suppressant, craving, slow gut emptying, insulin resistance, and so on. And I think what made the difference and what made the impact is the use of those medication. This is where they work, primarily on the brain to reduce appetite and satiety. Semaglutide, GLP-1 receptor agonist, works on the brain and on the gut, slowing movement. The tirzepatide is a GIP, GLP, and it acts also on the lipolysis. Very important cautionary issue. We're finding a lot of increase in pancreatic enzymes in patients who are on tirzepatide. It's very important to keep an eye, and I have done a little study. And usually it's asymptomatic. Semaglutide 2.4, around 15 to 20% reduction in weight. Tirzepatide, a little bit more on the weight aspect, about 22% reduction. What's the most of all this clinically weight loss? As you can see, sleeve and the GLP-1, GIP, and of course the others. We're dealing with medication that is beyond diabetes, beyond weight, cardiovascular, and it has shown to have a huge impact on giving you clinical benefit. The GLP-1 receptor agonists work in type 2 diabetes, CKD, MACE, obesity, and HFpEF. And of most important aspect is outcome. The SELECT trial is a trial of patients who are obese without diabetes. 17,000 patients with comorbidities, MI, stroke, and peripheral artery disease, randomized to placebo or semaglutide. Magnificent, quite impressive weight loss, but most importantly, impacting blood pressure, lipid profile, and hsCRP. And that amounts to a 20% reduction in MACE. So, therefore, last two slides, we need to treat obesity as a chronic disease. You take the medication, you lose weight. If you stop, it goes up, like hypertension. So ideally, we need to achieve weight loss, and usually it's a window of 6 months, and then you need to maintain this weight loss, and most importantly, you need to provide a clinically meaningful benefit, reduce diabetic risk, help manage diabetes, reduce cardiovascular risk, reduce functional impairment, and improve quality of life. Thank you. Thank you very much.
Excellent. Thank you very much, Professor.